Better. Let's come. Started. Okay. Started. Okay, friends. Now to continue our lecture on leprosy. Last time we discussed in detail as to how to examine a case of leprosy. Today we'll go further into whether leprosy can be controlled, leprosy can be eradicated, and what are the programs which are there in our country for the treatment of leprosy. So we'll just go into the details of this. So is leprosy eradicable? Why should we say that leprosy is eradicable? I mean, let's discuss the pros and cons. The epidemiological criteria which is against eradication of leprosy is that leprosy, as we talked about it, there's a long and variable incubation period. The mode of transmission is still disputed, whether it is transmitted by the oropharyngeal route. We really don't know much about this disease so much since, despite the fact it has been there with us since ages. Subclinical cases are very difficult to diagnose. Very difficult to diagnose the subclinical cases. We can't detect them. So if the subclinical cases are transmitting the disease, it's very difficult to catch hold of these people and treat them so that we can control the disease. There's a complicated disease spectrum, different types. You've got tuberculoid variety, you've got lepromatous variety, you've got pure neurotic, just pure neurotic. Only the nerve is involved. So the spectrum of disease is very complicated. The failure of cell-mediated immunity in lepromatous leprosy is also a problem. And bacterial persistence takes place. So that's also very. There is no vaccine. Till today, no vaccine has been made for this particular disease. And that's the reason why it can't be controlled. The social and cultural taboos. If a person has got a patch, he tries to not disclose it, because there are social and cultural taboos. So that creates more problems, that creates chances of transmission taking place. Extrahuman reservoir is also known, so that's also a problem. Now, what is the criteria for eradication of the disease? You see, we did say that there's a doubt whether there is be a host other than man, but mostly it is accepted that man is the only host. We do have armadillo, etc., but armadillos don't come in contact with men so much. Okay. The pathogenicity of the agent is very low. It's a low pathogenicity. It takes a long time for the disease to develop. We have got now some excellent treatment multi-drug regimens which are there, and they are very effective. A patch is there, you can recognize it so easily that it is leprosy. So it is easily recognizable. The bacteria grow very slowly. Also, there's a very low secondary attack rate. The secondary attack rates which are there are very, very low. You see in COVID, it's so high, while here in leprosy, it is so low. It has been eliminated, that means it has come down, the incidence has come down dramatically, so we can think of eradication. So based on that, there was a WHO Global Strategy 2016 to 2020 that basically said you must strengthen the government ownership, coordination, and partnership. You don't leave it to the private sector to eradicate the disease. The government has to take action, coordinate and plan the eradication program. You have to stop leprosy and its complications. Complications of leprosy, we talked about the disease burden, the deformities which takes place, so we must try and stop that. Stop the discrimination. If you stop the discrimination and let all the cases come ahead, there's no social ostracization, then you will find that people will come out and say that they've got the disease. Promote inclusion. Also, the key targets would then be that there should be no disability, and especially no disability in children. If disability is there in children, that means that the child has been having the disease right from possibly from a very young age. That is a very poor sign of control. So zero grade 2 disability in children, zero grade 2 disability in new leprosy cases. See, whenever there are cases less than a case per million, that means that the number of cases is going down. If the number of cases is going down dramatically, then why is it that a person that we are having grade 2 disability? That means we are neglecting cases. Despite the fact that we have got less cases, if the grade 2 disability is there in the population, that means we are neglecting even those cases which are there. So that means we are not doing a good job. So we must ensure that grade 2 disability is not there in places where there's less than one case per million. And all countries should pass legislation which does not permit discrimination. Example, our own country, we had a law by which a person could have divorce if his partner had leprosy. So it's a simple this thing which is there, that even a country where like India had such discriminatory laws. So these, of course, this has been removed from the statute now, but these laws were there. You have to accelerate towards a leprosy-free world, and to reduce leprosy burden and sustain leprosy control activity. That's basically you have to keep on sustaining the activity. Use case detection as the main indicator. You have to find the cases. You have to go to the community and find the cases. Ensure high quality diagnosis, case management, recording and reporting in all endemic communities. Strengthen routine and referral services, and discontinue the campaign approach. So what are the campaign approaches? You go into a community and start looking for cases. It should not be that way. We have to look for cases all the time in all places. That is most important. Develop tools and procedures that are community-based, integrated, and locally appropriate for prevention of disabilities. Basically, disabilities should not be there. Promote operational research in order to improve implementation of sustainable strategy. Operational research basically means that suppose you have got a program, and how the program is being taken to the community or how the cases are being detected, the how in everything is operational research. How is it being done, and if it is being done well or not. Encourage supportive working arrangements with partners at all levels. Okay. So for doing that, we would have different measures. One is the medical measures, the social support, the program management, and the evaluation. Always, whenever you look at a control program, they'll always have most of these things, other than social support, possibly may be different, but medical measures and control measures which are there of other types. So let's look at what are the medical measures. What would you do? Actually speaking, you have leprosy cases, you're aware of the leprosy, you're aware that they are there in the population. The first thing which we must do is to detect the cases early. Next, after that, you would like to treat them, and the best form of treatment is the multi-drug regimen. After you have treated the cases, when you're treating the cases, you must also have an overview as to find out more cases. For that, you need to have a surveillance mechanism. And to have this, when you have the surveillance mechanism, as I've gone on emphasizing, if there are deformities, it means that there is a problem. So find out deformities and manage those. You can't leave those people just like that. So deformities management and rehabilitation of those cases is a part of the medical measures. And very important, whenever I keep saying this, you as a doctor, your treatment does not end without a health education to each and every patient, so including cases of leprosy, whether you do health education to the patient or to the general population or to the contacts of these leprosy patients. So whenever you have to detect cases, you have to have a clear-cut definition. And the WHO then defined this leprosy case as a person showing clinical signs of leprosy with or without bacteriological just a minute, I'll just come back. Sorry, we just went off for a few minutes. Basically, I had some very important job to which came off in between. Okay, so as we were saying, a leprosy case is a person showing clinical signs of leprosy with or without bacteriological confirmation of the diagnosis. You do not require a bacteriological confirmation, and who has not completed the full course of treatment with the multi-drug regimen. Patients with residual disability should not be included in this particular thing which is there. So basically, any person who has a patch, or you don't have to really start looking for bacteriological confirmation or any other confirmation which is there. We then label them as leprosy. So there are different types of cases will be there. New case is a person having a skin patch or patches with definite loss of sensation and has not received a course of multi-drug regimen. An old case is a person who has a skin patch or patches with or without loss of sensation and has received a full course of multi-drug regimen. So new case and old case. Now, how do we manage these cases? Basically, what we have required to do is to estimate the problem in the community. We look at how much is this problem in the community. Very, very important that as a public health person, we have to know how much is the problem in the community. If you don't have the how much, you don't have a sort of a guess estimate, or generally it's not a guess estimate. It's an estimate which we make with some surveys. We have to know how much is there, because we have to plan for how many doctors we require, how much medicines we require, how much of deformity is likely, what is the rehabilitation to be done, what are the efforts which we have to put in health education, what are the chemoprophylaxis to be done. All these things we require to think of, and that can be done only even once you do a estimation of. Then you have to do a early case detection, put those people on treatment, do a good surveillance, manage the deformities and rehabilitate them, health educate, and protect the people who are at risk, including those who are contacts. Whether we do chemoprophylaxis or immunoprophylaxis, we'll discuss all these things. So how do we estimate? Estimation basically is to define the case load in the community for planning, implementation, evaluation, as I said. So for that we do random surveys. Surveys should give the prevalence, age, sex distribution, what is the form of leprosy which is there, and what are the facilities available to deliver the health care. And what do we do as far as early case detection is concerned? Early case detection, you identify and register all cases of leprosy as soon as possible. So what are the tools that we employ is that if you have one case per 1,000 in a community, less than one case per 1,000, then you're looking at a very small population, isn't it? You look at it, think about it. If there are very few cases, that means less than one case per 1,000, then every patient who comes, you look for their contacts, whether the contacts of this patient will be having leprosy or not, because it's more likely that it's being transmitted there. While if it is more than that, then we are looking at larger groups. That means it's being transmitted in the population. I'll give you an example. In COVID, we have been talking about the the government has going on saying that there is no community transmission. So basically, contact survey would be done when there is no community transmission. Group survey would be done when there is community transmission. In community transmission, there are more cases which are there. So we are looking at screening of school children, slum dwellers, recruits, military. Wherever there is there is a group of population, and the contact is more. Contact is more. Okay. Now, mass surveys is done when there is mass survey is done when the prevalence is greater than 10. That means there's a hell of a lot of people in the who are having the disease, more than 10 per thousand, and survey can should cover a huge number, because 10 is hell of a lot of cases which are there. You are having about 10 means about 1% of the population, which is very, very large. So you have to do a massive survey. Now, the good point is rifampicin is such a wonderful drug which we have got, and it is a highly bactericidal drug, which in a single dose of 600 milligrams kills 99.9% of the viable organisms. Excellent. Just one dose of 600 milligram kills all the organisms, and so it's an excellent drug. And if you give more doses, the frequent doses do not show any enhancement in the rate of killing. So give one dose per month. That's what we are doing. Also, whenever if 99.9% of viable organisms are being killed, just imagine if the contacts also are given one dose, you're making them you're preventing the disease. Also, if you give this one dose, the person becomes non-infective. It's an excellent drug, and so we must look at rifampicin as the mainstay of treatment. So there are three types of drugs, three drugs which we normally use: rifampicin, dapsone, and clofazimine. Rifampicin is highly bactericidal, and you can give it in one single dose of 600 milligram. Of course, this is different. This thing which is there is expensive. The adverse effects are there: nausea, anorexia, shock, and collapse. Please don't take the dosages from here. Dosages, I have another slide for that. Dapsone is weak. Has been used since ages and ages. We have used dapsone, and dapsone is generally given as 1 to 2 milligram per kg body weight. It's cheap, but it has some adverse effects like anemia, dermatitis, neuritis, hepatitis. And clofazimine is less effective. It's got an anti-inflammatory effect, no toxicity. However, it's unacceptable to patients, because what happens is there's a red discoloration which takes place of the skin. You see, wherever there's a patch, that skin patch may become reddish in color. Mucous membranes will become reddish in color. So sweat, urine, everything becomes red. So what do we do as far as the multi-drug regimen is concerned? This thing is dapsone. We are still relying on dapsone, recommended in the multi-drug regimen in 1981, and been given free of charge, of course. The objectives were to interrupt transmission, early detection and treatment, and prevent drug resistance. Advantages of multi-drug regimen is the shorter duration. Otherwise, we used to give treatment for 5 years for leprosy. 5 years. Yes, 5 years was the leprosy treatment. 2 years and 5 years. You have so now it is just 6 months. Patient compliance is better, cost effective, workload is less. It's safe during pregnancy and not contraindicated in HIV. These are the drugs which are available. If the first line treatments are not available, not useful, then we can use ethinyamide, protonamide, quinolones, minocycline, and clarithromycin. So what do we do? For multi-bacillary cases, we give rifampicin 600 milligrams once a month and dapsone 100 milligrams daily. Clofazimine 300 milligrams once a month and 50 milligrams daily. Duration of treatment is 12 months. 12 months for multibacillary, 6 months for paucibacillary. Please remember this. Multibacillary, 12 months, paucibacillary, 6 months. Okay. Now, in paucibacillary, you are again giving 600 milligram once a month rifampicin, dapsone 100 milligrams. Over here, you are not giving clofazimine. Clofazimine is for multibacillary. Paucibacillary, do not give clofazimine. And for single patch, which is very common in India, where single skin lesion paucibacillary, there is an alternate treatment which is there. There's what we call the ROM treatment. ROM, rifampicin 600 milligrams, ofloxacin 400 milligrams, and minocycline 100 milligrams. This is also given in the pure neuritic case. We give this rifampicin 600, ofloxacin 400, and rifampicin and minocycline 100 milligrams. One single dose. This is the treatment for children. I will not go into details of it. People who want to note it can note it down. Basically, 10 to 14 years, you're giving 450 milligrams of rifampicin, while smaller children, you like to give 300 milligrams. It depends on the weight of the child that you want to give. Clofazimine continues to be at 50 milligrams. That is this thing which is the regular daily dose of clofazimine, whether adult, child, is same, 50 milligrams. The loading dose, we might change it, clofazimine 300 milligram, 150 and 100. But generally, we are looking at clofazimine to remain the same. Dapsone will give 50%, that is 50 milligrams. So this is similar to what we have already discussed. So we can jump this slide. Yeah, I wanted to show you this because this is exactly what is being given in the multibacillary adult blister pack, which is there, is something like this, where you have the tablets of, what do you have, once a month, which is being given is 2 capsules of rifampicin, that is 300 milligram capsules, 2 capsules 600 milligrams, 3 capsules of clofazimine, that is 100 milligram capsules, which are the three of them 300 milligrams, and 1 tablet of dapsone, that is to be given first day, and the rest, for the rest of the days, for 28 days, you will be taking one clofazimine 50 milligram and 1 tablet of dapsone 100 milligram. The full course is 12 blister packs. Every month you give this. Person takes one strip, finishes off. When he comes back with an empty strip, you give him the next strip. Child one, see the color. This is the color for the adult, and the child color is brownish pack, which is there, so that we can discriminate. It's a similar pack which is there for children 10 to 14 years. That is multibacillary. Now the paucibacillary greenish color pack which is there, where you give 2 capsules of rifampicin, 1 of dapsone, and then the rest dapsone only, which is there. And that's only for 6 months, while there you were giving it for 1 year. And this is the one for the child. Different colors, so that it can be differentiated and we don't have a confusion. Again, let me repeat: multibacillary blister pack 12 months, paucibacillary blister pack 6 months. Multi-drug regimen is not contraindicated in HIV infection. Please remember that. Leprosy is exacerbated during pregnancy. We have exacerbation of the lesions which are there, but you must continue the multi-drug regimen. No report of adverse effects on the fetus. Drugs are excreted in the breast milk, and they will give protection to the infant till the weaning takes place. Please again remember that if the mother is taking clofazimine, the child will get a skin discoloration of due to the breast milk which is there. Don't worry, it will go off. There is no problem. It can still be continued. Now, the next thing which we need to know of is Lepra reaction. Now, the Lepra reaction is an immunologically mediated episodes of acute, subacute inflammatory reactions, unless treated, and nerve damage leading to deformities. So this is basically what is a Lepra reaction. It's a reaction which is there. It does not mean that, it does mean that there are some problems which we can handle. It's a known complication of treatment. So we must try and look at these Lepra reactions and treat them adequately. Two major types are there. Type 1 reaction, Lepra reaction, which is more in borderline leprosy, also known as a reversal reaction, and erythema nodosum leprosum, which is the type 2 reaction. Type 2 reaction is mostly in multi-bacillary, less in common in patients with the multi-drug regimen, but it could occur, it can occur. Now the type 1 reaction, now the reversal reaction, needs urgent treatment, which is there. You require to give prednisolone 1 milligram per kg body weight, gradually tapered for 10 to 12 months. And the erythema nodosum leprosum, which is there, with nerve involvement, minimal, can be treated with aspirin. It's only if it is the type 2 reaction is severe, then you require to give prednisolone. So first you have to differentiate between the type 1 and type 2 reaction. The early differential diagnosis of reversal reaction from relapse in possibacillary cases is important. The reaction is within 6 months of chemotherapy. Onset is abrupt. Lesions are edematous and tender, or new lesions are coming up. Lesions may ulcerate, and there may be multiple nerve involvement, fever, malaise, and arthralgia, or rapid response, and there's a rapid response to steroids. So let's look at the differences between the type 1 reaction and type 2 reaction. Type 1 reaction is seen more in borderline type, or seen in all types, but more in borderline types. Type 2 is not seen in the possibacillary, it's seen in lepromatous, borderline, or in the borderline lepromatous. And type 1 causes a permanent nerve damage if not diagnosed early, while type 2 is a recurrent and chronic nodules, neuritis, ulcers, pustules. These can occur. Treatment of type 1 reaction is by steroids, type 2 reaction is by aspirin, and only in severe cases you give steroids. Now, what do you do as far as surveillance is concerned? Surveillance is essential for the assurance of success of treatment and for early detection of relapses. So in possibacillary cases, the possibacillary cases are examined clinically at least once a year for a minimum of 2 years. So we're giving treatment for possibacillary for 6 months. So we're going to give them, we're going to observe them for a minimum of 2 years after that. So after completion of treatment, every year there is to come for review to check whether there are any relapses or not. For 2 years at least they should come. Multi-bacillary, they should be checked once a year for 5 years after treatment. 5 years after treatment. Now the rehabilitation, disability rehabilitation program which is there, basically looks at people who have Lepra reaction or prevention of occurrence of disabilities. And with persons with Lepra disabilities, we give them care and support and ensure that there is no worsening of the disabilities. Person with deformities, suitable correction is done by reconstructive surgery. So what are to be done? If leprosy didn't cause deformities, it would not be a dreaded disease, and social stigma would not be there. So the deformities we've already discussed: medriosis, facial deformities, lag ophthalmos, wrist drop, foot drop, anesthetic deformities like corneal ulceration, scar contracture of fingers, mutilation of hands and feet. These are, you can see various things which are there. The lowermost is a skeleton which has had deformities. So you can see these deformities do take place. Prevention of deformities is by giving early and complete multi-drug regimen, Patient should take care of his anesthetic extremities with daily looking after the skin, cracks, wounds, and ulcers, protective gloves and footwear, and physiotherapy provides symptomatic relief, and neuritis, etc., can be looked after. I am not going into details, though I have got lots of slides on this. I'll just run through. What you can do is prostheses, orthopedic devices, reconstructive surgery, tendon transfers. You can stabilize the joints, and you can give physiotherapy. So as I said, there are a number of things which are there. Rehabilitation, you can do a preventive rehabilitation, medical, psychological, vocational, social, economical, and resettlement of people can also be done. Health education is very important. We must do health education not only of the public, patient, and the family, but special groups, children, school teachers, NGOs, medical practitioners. All sorts of health education requires to be done. Now, protecting the people at risk. Basically, what we are looking at is disinfection of the nasal discharge which is there. Ensure that it is disinfected. You can use any of the disinfectants which is there, and ensure that that the nasal discharge is collected in a bowl which has got a disinfectant. And the housing sanitation standards should be good. We should have good ventilation. Chemoprophylaxis can be tried. Malnutrition has to be curbed so that the immunity improves. And what do we do as far as chemoprophylaxis is concerned? We'll talk about that. We do give chemoprophylaxis to close contacts. Let's go straight into that. As far as contacts and children are concerned, the chemotherapy which we use is dapsone given orally, and we can give it once per week. There is also a concept of giving acidapsone injection parenterally. These are all trial things which we will not want to do. Dapsone can be given until the index case becomes bacteriologically negative. Now, this is still controversial because, as I told you, giving one dose of rifampicin will make a person non-infective. 99% of the people become 99% of the bacilli are killed. So, giving chemotherapy is rarely practiced nowadays, and we prefer to give rifampicin to the patient and ensure that the patient doesn't come in contact with the family for a few days at least, and then the person becomes non-effective. Immunotherapy, very controversial. BCG being given, very controversial. It's just studies which are there. There are certain vaccines which are being tried based on mycobacterium leprae and based on cultivable mycobacteria. A lot of people trying out various vaccines with BCG, without BCG. Nothing which has reached fruition till now. As far as India is concerned, the National Leprosy Eradication Program is a program which is in the Ministry of Health and Family Welfare. We have a Deputy Director, Health Services. This was a vertical program earlier. Now it's become a horizontal program. So a lot of it has been cut off. So this is how it went. 1955, dapsone was introduced in India. Then 1970, there was this multi-drug regimen was identified, and then 82, it was used widely. 1983, where National Leprosy Eradication Program was brought into being. 1993, we had a World Bank support for the MDT program. We did a midterm appraisal in 1997, and the Modified Leprosy Elimination Program was launched in 1998. So then we had the phase 2 from 2001 to 2004, and then after that the NRHM came on. I hope you know what is NRHM. National Rural Health Mission came on, which covered NLEP. And in 2005, India achieved the elimination of leprosy as a public program. That means elimination meaning that prevalence rate was less than 1 case per 10,000. As you know, we mentioned that our status is 0.66 per 10,000. So elimination of leprosy is prevalence less than 1 per 10,000, which we have achieved. We have a disability limitation, disability prevention and medical rehabilitation program, which is there. Basically, since it is now a horizontal program, it is ASHA workers who are supposed to look for cases. Each case which they get diagnosed as 250 rupees they get. On completion of treatment for a possibacillary, they get 400 rupees. Multi-bacillary, 600 rupees. Basically, it is money. If you give money, possibly people will work. So that was the whole idea behind this. Household contacts, when we do a survey, look for multi-bacillary cases, try and prevent further cases. So lots of things being done. Now, in the post-elimination strategies, we continue to look for new cases. Treatment completion is what we are looking at, and we strengthen the disability prevention and medical rehabilitation program. There are various, as I mentioned again, money is being thrown around. 80,000 rupees for reconstructive surgeries are given extra. 5,000 is given to the institute. Basically, these are incentives given so that people take up the job of elimination or eradication rather. Information, education, communication in the community is carried out at the PHC and other levels, and intensive monitoring and supervision is carried out. So prevalence rate, if you look at, we talked about this earlier, we are less than 1 per 10,000, 543 districts are, this is the old slide. We have almost achieved elimination in most of the places. The annual new case detection rate also is below 10,000 nowadays. It's 0.66, and cure rate is high. So the evaluation of this, basically we have various parameters for evaluation: proportion of new cases with grade 2 disabilities, proportion of child cases, proportion of female patients, proportion of multi-bacillary cases. These are all indicators which will for evaluation of case detection, and indications of quality of services, new cases which are verified, defaulters or number of relapses, and proportion developing additional disability when on multi-drug regime. These are all evaluation techniques. Some challenges remain. Some of the states continue to have, now this 99 districts have been cut down to I think 20 districts which are there, which have leprosy as a public health problem. And multi-drug therapy requires to reach, now especially during this COVID time, there's been a lot of problems because drugs have not reached, patients have got worse. So we have to look at now recouping. Poor treatment complete, place where you are required to give treatment for long, the treatment completion is the problem. Fear, prejudice, and stigma surrounds leprosy, so to look at that. This is the Leprosy Eradication Program 2017 change, which is the leprosy case detection campaign, focused leprosy campaign, house-to-house search for grade 2 disability, special plan for hard to reach areas, and the Sparsh leprosy awareness campaign. These are the prime things in the Leprosy Eradication Program 2017. And the additional challenges which are there are decreasing expertise resources, services for the complicated cases, and there is an emerging drug resistance which will create problems. That's all in leprosy. I hope you all will read up more about leprosy. It's a very important program, very important that we eradicate the disease. Look at it, and if you've got any queries, you're most welcome to message me or send me a email, and I'll try to answer your questions. Thank you.